डॉक्टर साहब ये बाद में कर लीजिएगा पर्चियों का सिलसिला ना, थोड़ी देर के लिए बंद कर दीजिए। So how many Pakistani psychiatrists? If you look at it, these 450 are not qualified psychiatrists. These are the practicing psychiatrists. While in two countries, the total number of qualified psychiatrists which are Pakistani in origin, and I'm not talking about Australia, New Zealand, and other countries, a substantial number of. So definitely we have. When we discuss this and the situation, if you look at another aspect, that majority of the population that is living in a rural area. But if you look at the number of psychiatrists who are practicing, mostly they are based in cities. So there is a strong disparity. But things are not going to end up over here. The situations are not very good in big cities also. If you talk about Karachi, the conditions are not very encouraging. I'm just talking about Karachi. There is a population of 15 million in Karachi, and there is a 500,000 psychiatric patients, and there are only 70 practicing psychiatrists working in Karachi, and hardly there is any psychiatric nurse who can take care of the 600 psychiatric pack in Karachi. The situations are not very good. Why I am talking about all this is because it is very important. Because these psychiatrists, I was talking about 500 psychiatrists, they are not taking care of the 180 billion population of the Pakistan. These psychiatrists are also providing, covering almost all of the patients coming from Afghanistan, a substantial number of the patients coming from the Iran, from the western border people are taken care of. So that means that our capacity is very low, and that makes us that to deal with it, how can we deal with these problems? So when I look at the curriculum, in all the developing countries, if you look at that behavioral science was a major subject in all the developing countries, but it was not, and it has been recently been incorporated. What about psychiatry? The clinical side, psychiatry is a major subject equal to surgery, medicine, gynecology in all the developing countries. But in Pakistan, it was just a minor subject and no importance was given. And what was the impact of that? Impact of that was that our level of the knowledge of medical specialists and medical people. So what we did, we conducted a study in Karachi, and this study has been published in International Journal of Psychiatric Medicine in 2012. What we did, we contacted the family physicians and asked them few questions regarding their knowledge about the psychiatry. If you look at this, the medically unexplained symptom, the 60% of the physicians believe that they are difficult to manage. But if you look at that, they have undiagnosed physical, they believe that medically unexplained symptom, basically they are undiagnosed physical problem. Because of that, what they are going to do, they are going to put them unnecessary investigation and unnecessary medication for them. And not only that, that if they ask that they have a psychiatric illness, they strongly disagree. 80% of them strongly disagree that they don't have any psychiatric problem. So this was the state of knowledge that motivated us to do something, and what we do. And not only this, when we ask you other question, not to get involved in the treatment, they strongly disagree, and then they have no involvement. Most of them say they difficult patients say we don't involve in their treatment, and prescribe psychotropic medications, they strongly agree with that. With this, what we did in Dow University, we realized that there is a component of training at undergraduate level for these people who are basically going in the market later on. So what the Dow University did, that integrate psychiatry and behavioral sciences in their curriculum, and the university started postgraduate diploma program. Not only that, the research is being conducted, we are going to involve community health facilities for that, and trying to develop many non-pharmacological interventions for that. This is not time to discuss with that. But if you look at that curriculum of Dow University, and you need to pay some attention. In Dow University now there is no, specialties. There is no anatomy department, no physiology department, no biochemistry department. Now the departments have been finished. Now what we have done, that there are the modules have been introduced, and we face a lot of resistance from the people from the basic science because they want to leave their domain. Now what we are doing, that if you look at that, the first year and second year, it is the first spiral. While second year and third year is the second spiral, and final is the third spiral. If you look at that, each year is being divided into 2 semesters, first semester and second semester. And each semester have different modules, these are the different modules. But one thing I want to highlight, that these, for example, respiratory module is being run in a first spiral, same respiratory module is being run in the second spiral. The renal module is run in the first spiral, same is being. So what is the difference? The difference is this, that in the first spiral, the basic science teachers are going to involve more and going to teach more basic science subject, but that is being controlled by the clinicians, and clinicians are going to guide them that this we want this student to learn. And in second spiral, there will be more clinical, but basic science subject people are also being involved in that. For example, when we were students, we were taught about the foramen chart. We were to learn it by heart, but my principal, I was talking to him, Junaid Ashraf, he said, being a neurosurgeon, I never use foramen chart in my practice. So what is the use of burdening the student with this extra knowledge? For example, being a psychiatrist, I need a physiologist that to taught that how the thought is going to be developed and what are the different processes being involved in development of thought. When I talked to the physiologist, nobody was able to teach about that. So that if they are not teaching it, that is of no use. So this integration, what this is highlighting more things, and now the students are more versed with a more practical and more focused knowledge. Integration, this was a difficult part, and this was because BMDC have allowed the Dow Medical College, Dow University of Health Sciences to experiment with this curriculum. And what we did, the second part was, and as you see that neurosciences module is being into, here is the more basic science and here is a pure, and we have integrated psychiatry in this module. And now student has to pass each module. If he is not going to pass each of the module, he cannot be promoted. So it is a restriction if you have not enough knowledge of psychiatry in there. The difficult part was integration of different topics of the behavioral sciences into the different modules. And for example, if you look at this, these are the different topics which we have introduced in the different topics in different modules. These are the different topics of the behavioral sciences. For example, in the cardiovascular module, we integrate stress management in that. And for example, in renal module, we integrate ethics and organ donation. So like that we try to. Few of the modules which cannot be integrated, they were running parallel to other modules. And in this way, not only this was our effort we took, and this is the second spiral in which you can see that the different modules are being run. And we also take help from other experts regarding the development of this. This was a feedback given by a Dr.